Hello. In this part of the Advancing Bronchiectasis Awareness and Educational video series, I'd like to address what to do if you suspect your patient has bronchiectasis. First and foremost, it's important to establish a radiographic diagnosis for bronchiectasis, generally done by high-resolution chest CT scan. Criteria include having an increased bronchoarterial ratio of 1 to 1.5 or more, lack of bronchial tapering, and bronchi visible within 1 centimeter of the pleura. Associated conditions commonly involve bronchial wall thickening and mucus plugging. The severity of these findings may vary from very mild to more advanced disease. In most instances, symptoms are proportional to the severity of radiographic findings. It's important to also realize that bronchiectasis may be an entity in itself in a single etiology. In other instances, there may be other comorbidities. Those other pulmonary diagnoses that are associated with bronchiectasis include COPD, asthma, inflammatory conditions, including scleroderma, Sjogren's syndrome, connective tissue disease, as well as rheumatoid arthritis. Other types of pulmonary diagnoses include pulmonary fibrosis and radiation-induced damage. Other associated conditions that oftentimes contribute to or may exacerbate bronchiectasis include gastroesophageal reflux disease and esophageal dysmotility, with or without aspiration. Chronic sinus disease with chronic rhinosinusitis is common as well, and other infections that include bacteria, mycobacteria of fungi are also common. Point here is that when there are associated conditions, oftentimes symptoms that are attributable to bronchiectasis may improve by treating some of these comorbidities, whether they're associated lung conditions such as COPD or asthma, or other non-pulmonary associated conditions, including gastroesophageal reflux disease or chronic sinus disease. By addressing these issues and paradigm of recurrent infection leading to inflammation and further airway damage, we set up the historical paradigm of the vicious cycle. When our patients present with bronchiectasis, we oftentimes will obtain pulmonary function tests to further assess the natural course of the disease process, commonly collect sputum samples either by spontaneous method or induced sputum for bacterial, fungal, and mycobacterial pathogens, and then diagnostic blood tests for potentially, albeit less common, reversible and treatable traits. This includes immunoglobulins, such as may be seen with hypogammaglobulinemia, alpha-1 antitrypsin deficiency, and genetic screens such as cystic fibrosis and primary ciliary dyskinesia. I might also add that the awakening and explosion of CFTR-related therapies for cystic fibrosis, including those adult diagnosis CF patients, have expanded our approach to potential therapeutic strategies. Autoimmune screening may also be appropriate in select patients. This leaves us then with the mindfulness and the importance that an early diagnosis of bronchiectasis is associated with more positive outcomes. The sooner the diagnosis is made, the lack of a delayed response, the better the outcome.